Let's see. I think people is entering now. Yeah, people keep entering. We're gonna wait for at least more people to come in, so we start the webinar in a couple of minutes. Okay, it is. Okay, we're gonna start now. Good afternoon and welcome everyone to our third NLAAD 2020 webinar. My name is Luis Mares. I am the Director of Community Mobilization Programs at the Latino Commission on AIDS and coordinator of the National Latino AIDS Awareness Day since 2017. We are very excited to continue our series this year with a topic of great importance in the HIV field, which is advancing the ending the epidemic initiative during COVID-19. As we know, the federal government announced last year the plan to end the HIV epidemic in America for the year 2030. Today, we will learn about the impact that this new pandemic COVID-19 has on the implementation of the plan, if any, and what progress has been done towards the goals set last year. And to talk about this important topic today, we have Harold Phillips from the U.S. Department of Health and Human Services. But before continue, we are going to give you a little bit of housekeeping, and we're going to talk about a little bit about the NLAAD campaign. So you know this webinar is being recorded, and whoever is not mute automatically by the system, please mute your microphones. And I ask you to write your questions in the question and answer section, not in the chat, because it's easier to find them there. And also, once the webinar is done, I will share with you a copy of the PDF version and the link for the recording. So, NLAAD National Latino AIDS Awareness Day 2020 is our 18th year organizing the campaign with the same efforts to create awareness among the Latino community, Hispanic community about HIV and supporting the ending epidemic plans. We ask you to promote the campaign by posting on your social media platforms and using the hashtag NLAAD2020, HIV fingertips, and NLAAD. Earlier in the month of September, we launched our NLAAD 2020 campaign, and you receive an email probably with this information and the images of our campaign. This year, we decided to have 6 posters instead of 1, and each one focus on one of the tools that we have to end this epidemic. No, the advances of science and medicine have done in 40 years of the epidemic. Help us to be able to say that we can end this epidemic by the year 2020. We have access to rapid testing. We have now preventive measures that work very effectively, and that's PrEP and PEP, and still the use of condoms. And also we have very effective treatment that improves the health of people living with HIV, allowing them to reach viral suppression, and therefore also eliminating the risk of transmission of HIV by sex from people living with HIV. And we know this as treatment and prevention, and we also know it's a U equals U. Each one of these tools, as I mentioned, is represented in one of the posters of this year. And with all these tools I mentioned, we can identify those living with HIV who do not know they have it. We can reduce significantly the risk of transmission, and we can prevent new infections. We also ask you to visit our website, nlaad.org. Okay. Where you can browse the website about the campaign, but you also can browse the website to find about information on HIV, prevention, treatment, testing, where to get tested, where you see you can get referrals for PrEP or billing to treatment. But we also ask organizations to go to the website to register their NLAAD events, and the registration link that appears in the website. And this will take you to a different page, which is a SurveyMonkey page, where we ask you to put all the information of your NLAAD event, which we knew this year was going to be lower than usual because of the COVID-19 restrictions. But we still ask people to plan their events, and if not want to have a regular event like every year, we suggest you to have a virtual event and still register with us. So we this is some of the events that appear in our website already. I also want to promote our next and last webinar, which is Undetectable and Transmittable, the message and the movement, with two of the U equals U ambassadors, Davina the Corner and Arena Lind, which is going to happen on October 22nd at 3 p.m. And before going into the webinar, I'm going to show you a couple of videos that have not been released yet, that were sent to me directly from HSS. It is specifically made for NLAAD and is focused on PrEP. So here they go. This in English. And
I am born and raised in Puerto Rico, so I come from a very machista society. One of the main cultural challenges that I see is dealing with one's sexuality. And now we can protect our bodies, we can protect our partners, and we can finally come to ending the HIV epidemic. We can change our narrative. I'm Damian, I take PrEP, and I'm ready to prevent HIV.
And this was in Spanish.
Soy nacido y criado en Puerto Rico. Culturalmente tenemos que lidiar mucho con esta idea de internalización de ese estigma por mi sexualidad. PrEP logra romper con esas barreras y decir, podemos proteger nuestros cuerpos, podemos proteger a nuestros compañeros sexuales y también podemos acabar la epidemia del VIH. Nosotros podemos cambiar la narrativa. Mi nombre es Damián, yo tomo PrEP y estoy listo para prevenir el VIH.
Thank you very much for sharing this with us. We'll be able to show it in the webinar. So for today's webinar, we are advancing the epidemic initiative during COVID-19. As I mentioned earlier, we have Harold Phillips. Harold Phillips works in the Office of HIV/AIDS and Infectious Disease Policy, Office of Assistant Secretary for Health at the U.S. Department of Health and Human Services as a Senior HIV Advisor and Chief Operating Officer of Ending the HIV Epidemic at Plan for America. So we have the right person for this, right? In this position, he oversees the coordination of the initiative activities, ensuring that all U.S. Department of Health and Human Services operating divisions are collaborating and communicating as they work to support jurisdictions in making the best use of the science, data, and tools we now have available to end the HIV epidemic. He will also work to ensure there is both community awareness and engagement in our efforts to end the HIV epidemic. Prior to joining IPD, Harold served as Director of the Office of HIV and AIDS Training and Capacity Development at the Health Resources and Services Administration's HIV/AIDS Bureau. OTCD administers the Ryan White programs, AIDS education and training centers, special projects of national significance, and support the U.S. President's emergency plan for AIDS relief. He also held past positions within HRSA and the Deputy Director of the Ryan White Part B and AIDS Drug Assistance Programs, ADAP. Working with Ryan White, HIV/AIDS program recipients, planning councils, providers, and patients, and served of the CDC HRSA AIDS Advisory Committee from 2003 to 2010. He has a master's degree in urban and regional planning from the University of North Carolina at Chapel Hill and an undergraduate degree from Kalamazoo College. So I want to stop sharing my screen. So Harold, you can go ahead with the webinar.
Thank you, Luis, and thank you to the commission. Luis, I do have a quick question. So yes. I should be sharing my screen in the slides, is that, or?
Oh, yes, that's what I thought.
I can do it. I can do it. No problem. Hold
Thanks,
on.
Marissa.
No
Thanks,
problem.
Marissa. No problem at all. Buenos Aires, everyone. I'm very happy to be here with you to talk a little bit about the ending the HIV Epidemic Initiative, and to also talk with you all about some of the efforts that have gone on in light of COVID-19 and where we are in the initiative, as well as the initiative and what we hope to accomplish in the Latinx community. I am happy to see in the chat the number of people who are from all across the country that are here this afternoon with us. I think it's really important to take a moment and to thank you all who have continued to provide prevention, care, treatment, and HIV testing services to those living with HIV and at risk of HIV, especially during this challenging time. Marissa, as we do this, are we using the Spanish or the English, just briefly?
So we are going to be displaying it in Spanish, but you have your copy in English, and you can present in English.
Gracias. So last year, I came and I presented, and it was just after I began with the Office of the Assistant Secretary. This year, I hope you realize we have done several things in response to what we heard last year. So this presentation, the slides will be in Spanish. I will be speaking in English, and we have both a Spanish language set of the slide decks as well as English. Hopefully, you all can use them both, and we're making them available as well. The video that you saw is a video that we have produced in association with HIV Awareness Month this month, but we will also be releasing new material that is part of our Ready, Set, Prep campaign that I'll talk about too. Marissa, next slide. So in the United States, you all know this, we have about 1.2 million people living with HIV in the United States. And only about 56% are virally suppressed. And that in our country, we have about plateaued for the last several years, around just below 37,000 new HIV transmissions on an annual basis. If we did nothing, we'd have approximately 400,000 new people living with HIV in the United States within 10 years. And this is important, and this is one of the reasons why we have the EHE initiative. Next slide, Marissa. So this slide talks about sort of what it looks like for our Hispanic and Latinx population, adults, and the sexual transmission categories. I think similar to what we saw on the last slide with the approximately 37,000 new transmissions, we've also seen a plateau of transmissions in the Latinx community where it sort of flattened out as we sort of have flattened the curve. We also see that we have had some success because part of that success is that we are not seeing large increases. But the fact that things have remained flat means that we need to do something different, that we need to begin to think about who are we not reaching with our messages and our services, and how do we engage them differently. Next slide. So looking at males, Hispanic and Latinx males aged greater than 13. I think when we begin to look at our data in a very different way, we can see where we've had both increases, where we've had decreases. And I think overall, what we have seen is a decrease in the number of young people who are acquiring HIV. Where we have seen also, we've seen some flattening, but we also see some slight increases when we look at our 25 to 34-year-olds and also 35 to 44-year-old men as well. So it's important that whenever you all are looking at data on the local level, that you begin to disaggregate it so that you can see these differences and see what's happening among different age groups, different population groups, and begin to think about how you might incorporate or do your planning a little bit differently. Next slide. So Marissa, there we go. And so this slide, I think, sort of shows what it looks like in 2018. Again, we're still seeing slight increases in some of the groups that I mentioned, those groups being 25 to 34 years old, and also 35 to 44-year-old. We're seeing increases, but again, even in 2018, we continue to see decreases in our 13 to 24-year-old. So again, it seems that we are reaching our young people with some of the messages as well. One of the things to pay some attention to on this slide for 2018, it does show what looks like a slight increase among those that are overall among those who are less than 55, but who are over 55. So this may be something that we need to look at, especially with the Latinx community as well. Next slide. So again, we can see in the United States the disproportionate impact of HIV on the Hispanic Latinx community, where you're 27% of the population of those, 27% of those new HIV transmissions in the United States. Yet we also have the issue of 1 in 6 with HIV are unaware that they have it, and more than a third are tested late in their illness or diagnosed with AIDS within 1 year, which also impacts their overall health outcomes, as well as their longevity, their ability to live long with HIV. We know that the earlier we can diagnose someone in their HIV progression, that the longer their lifespan, especially if we get them on antiretroviral therapy. Also, many of you are aware that PrEP use is less common in the Hispanic and Latinx among gay and bisexual men. So again, these points are raised so that as you think about ending the HIV epidemic, it gives us a little bit of an area of focus, some things to think about and consider both planning, but also the delivery and implementation of services to the community. Next slide. So, someone I very much respect, Dr. Anthony Fauci from the NIH, had said a couple years ago that we have all of the tools that we need in order to end the HIV epidemic. And here's what's important about this that often gets missed. That if we use our data to really and truly understand who's at risk for HIV, who is acquiring HIV, where they are geographically, and how we might reach them. If we apply the antiretroviral therapy and also being able to use PrEP and 25 years of proven models of prevention and care, if we apply all of these in a new and different way, we can end the HIV epidemic without a vaccine and without a cure. Now that's exciting because it will be for the first time in the United States, or first time worldwide, where we've actually been able to do that. So think about what we're going through right now when we're looking for a vaccine or a cure to COVID-19, and we're all sort of waiting. With HIV, we don't have to wait. If we apply these tools the right way in our communities and involve the communities in helping us figure out what are those right ways to do things differently, then we can end the HIV epidemic. Next slide. And people have asked me, Harold, is this possible? And what I point to is, if you think about, there are certain countries in Africa that received PEPFAR funds, and they did the same things that were on that last slide. And they have come to a point where they can have controlled their HIV epidemic. If we look at countries like Swaziland, if we look at countries, even looking at some of the countries that haven't gotten there yet, but countries such as South Africa, which folks were dying so fast in South Africa at one time during the HIV epidemic that they didn't have enough caskets to begin to bury people. And if you now talk to South Africans, they talk about how applying the science, applying what they've known, and involving the community, they've been able to reach the community differently with prevention, testing, care, and treatment. That while they haven't completely controlled their HIV epidemic, they have slowed it down to a point where they're no longer where they were 10, 20 years ago. So applying some of those principles with a strictly geographic focus has been part of EHE. So what you see on the screen are the 48 counties, including DC and San Juan, Puerto Rico, which total more than 50% of the new HIV diagnoses in 2017. Also, 7 rural states with a disproportionate rural diagnosis in those areas as well. EHE has a very aggressive set of goals, a 75% reduction in new transmissions within 5 years and a 90% reduction within 10 years. You also see on the screen the federal partners that are part of the US Department of Health and Human Services who are responsible for implementing the initiative itself. Now, when I talk about less than 90% new transmissions within 10 years, if you think back to an earlier slide, I talked about we've plateaued at 37,000, approximately 37,000 new transmissions on an annual basis. 90% or less in 10 years would mean that we would have 3,000 or less transmissions. So we've got a lot of work to do in order to reach that goal. Next slide. The initiative itself sits on what we call the 4 pillars. The first pillar is diagnose people with HIV as early as possible. To do this, we have to think about outside the box. We need to think about not only those who walk into the clinic or come to the public health department, but we have to think about how do we bring HIV testing to places where individuals at risk might be living and might not be aware of their status. So does this involve, in some communities, involving the faith-based community in HIV testing? Does this mean that maybe we're testing at homeless shelters or at food banks where we can reach people? Are we testing at our Hispanic serving academic institutions? Really thinking about that and thinking about what those new partnerships might need to look like. And then treatment. For those who are HIV positive, who test positive, linking them immediately to HIV treatment so that they can obtain and maintain viral suppression. So with treatment, what we also want to do is make sure that our treatment models are appropriate and that we reach people both with culturally appropriate treatment services. Prevention, very similar. For those who test negative, connecting them to prevention. And when I'm talking about prevention, I'm talking about the entire prevention toolbox. I know we have focused a lot through the EHE initiative on PrEP this first year, but I think we have to acknowledge that PrEP does not PrEP is not going to be the solution for everyone. That there is also behavior change. There are condoms. We need to think about the entire prevention box, as well as syringe services programs for those who are injecting drugs. So we need to think about all the tools in the prevention box. And then finally, the final pillar is the response pillar. Being able to use surveillance in a different way to be able to find, identify, and address cluster outbreaks of HIV within our geographic areas as well, and ensure that prevention and care services are deployed to those areas of the country where there are those outbreaks. Next slide. So, EHE and ending HIV continues and remains a priority of the federal government. Me and my team have been working continually focused on HIV since the beginning of the COVID-19 pandemic. We have also, as a result of COVID-19, worked on a number of strategies to help ensure that there is access to HIV testing, prevention services, and treatment. The shift among many of the providers, some of you are on this line, to telehealth models has been extraordinary to sort of see and watch. Shifting to multi-month prescriptions for those who are on PrEP, as well as those who are in treatment and needed access to their medications. All of the federal agencies, HRSA, CDC, SAMHSA, and IHS have put out additional guidance to their recipients around the use of HIV self-testing as a way to ensure that even in this age of social distancing and the COVID-19 requirements, that there is access to HIV self-testing, especially in those places where health departments have had to shift resources or many public health departments stopped doing HIV in-person testing. So self-testing as a methodology and as a mode of receiving HIV diagnosis has been promoted and embraced by many of the federal agencies and partners. For those of you who need more information on that, please visit hiv.gov, where you can find additional information on that and other aspects of ending the HIV epidemic. Next slide. And I'll kind of go quickly through some of these as well, because we sort of have talked a little bit about the pillars. So again, with the diagnosis pillar, our ability to diagnose and link individuals to care and treatment, which is so important to stopping new HIV transmissions. 8 in 10 of our new infections come from people who are not in HIV care. And so the importance of diagnosing them and connecting them to care can't be underestimated as part of our strategy to end the HIV epidemic. Next slide. We know the science is with us around HIV treatment as prevention. Many of you have heard the U equals U message. Undetectable equals undiagnosable. Undetectable, meaning that they cannot transmit the virus to others through sex. Really getting that message out to individuals living with HIV, but also making sure that our healthcare workforce understands this message and is able to talk to individuals about it. And then we use this also as a motivator to get people to connect to care, stay in care, and take your medication. Knowing that you can live a long, healthy life by taking your medications and staying in care can be a motivating message to people living with HIV. Because if you can do that, then all of your other life goals and aspirations can be reached. And that HIV doesn't have to be a death sentence. And I'm old enough to remember a time when it was. And so the fact that we are here today and that we can make sure that this message is shared among our communities, that is shared among our healthcare workforce, is a game changer. And it's such a game changer in that it's an important part of our overall strategy to end the HIV epidemic. Next slide. So we've got to use HIV diagnosis as sort of our gateway to prevention or treatment services. So the importance of the diagnosis pillar is that it can also serve as that foundation where we can then link those who test negative and are at risk for HIV to the comprehensive prevention services that include PrEP and syringe services programs, or those who test positive, linking them immediately to treatment. So many communities are thinking about sort of red carpet models where individuals can be linked immediately to treatment or as quickly as possible. And so those also have shown, we're in the process of evaluating some of those and looking at some of the results. But when you sit back and you think about it, HIV has historically been one of the only diseases where we have said to someone, you have a life-threatening disease, and we're going to wait to treat you for it. Some of that is because there was a time, one, when we didn't have medications. Two, there was also a time when we thought it was better to wait. But now we know better. And so we've got to change the dialogue and change the narrative so that folks understand the importance of immediate linkage to care and treatment, just like with any other infectious disease. Next slide. So there are many effective HIV prevention tools, and we need to think about all of them. But I'm going to spend a little bit of time talking about the Ready, Set, PrEP program, which is the HHS program that provides access to PrEP medications for those who don't have insurance and are at risk of HIV and have a negative HIV test. So for those individuals, this program can serve as a way to provide those PrEP medications. Next slide. We also recognize that there are still many people in our community and also in the Latinx and Hispanic community that aren't aware of PrEP, both what it is and what it does, and then also that there is access to PrEP medications if you don't have insurance. So those that are eligible for the HHS PrEP program, Ready, Set, PrEP, need to test negative for HIV. They need to have a valid prescription from a healthcare provider, or someone can help them get that valid prescription from a healthcare provider, and they can't have health insurance. So they won't have to pay for the medication. And also, we have a network of pharmacists, over 26,000 pharmacy locations where they can pick up the medication, or for those who are comfortable, they can also have the medication mailed, delivered through mail order at their house. Next slide, or to a post office box. Next slide. So as of March, we had, like I said, over 26,000 pharmacies across the country that were that are part of our network of pharmacists that are providing the medication. So they are there. They're also doing patient counseling and also taking steps to promote patient adherence to PrEP as well. So, and it also includes the 50 states, DC, Puerto Rico, and the Virgin Islands. And again, they do offer mail order services to those who would like it as well. These pharmacies are also providing a 90-day supply of medication so that many of those who are in parts of the country where we're still experiencing COVID-19 hotspots could still adhere to social distancing requirements. Next slide. So again, these are all the logos of the pharmacies that are involved and engaged in our program and have joined up and are playing their role in helping to end the HIV epidemic. Next slide. So EHE indicators. So how will we know and monitor our success in ending the HIV epidemic? If you haven't, I really encourage you to go to what I'm going to talk about next, the AHEAD dashboard, which you can find and you can link to it via hiv.gov. But the dashboard has broken out for each of the EHE jurisdictions, the counties and the states that are part of our phase 1, the 6 EHE core indicators that we are using to monitor our progress: diagnosis, knowledge of HIV status, linkage to HIV medical care, viral suppression, PrEP coverage, and those are our core indicators. Next slide. So with these core indicators, it has the AHEAD dashboard also includes not only the national goals and targets, but also the targets for 2025 and 2030 for each of the EHG jurisdictions. So when we are talking about nationwide, we need less than 3,000 or less new transmissions. It has broken out for each EHG jurisdiction, what are the targets and indicators for your particular jurisdiction. So again, this is a great tool to use when thinking about and planning for ending the epidemic in your community. And it covers all 6 of the indicators. And for the first time in the United States, we have set overall targets and goals toward our progress in ending the HIV epidemic. So you will be able to see where you are today using the 2017 data as our baseline and where you need to be in 2025 and 2030 to be on track and ending the HIV epidemic in your community. Next slide. So the AHEAD dashboard is a powerful tool that I think can help you all both in your planning and service implementation as we look at future iterations of the dashboard. And so I encourage you to check it out, if not today, then soon, but also come back because we will be continuing to add and to update the dashboard as time goes on. There will be parts of the dashboard that will be available in Spanish sometime next year. We are also doing work where we are creating an interactive portion of the dashboard, which will allow you to compare jurisdictions. So you would be able to see how San Juan compares to San Antonio, as an example, using the dashboard itself. Next slide. The AHEAD dashboard materials are also available and for download for those of you that are involved heavily in the planning of EHG in your community, or if you are part of a clinic or a public health department. Some of these tools, all of these tools can be shared and hopefully you will be able to find them rather both as part of the link, which my colleague Steve Holman is sharing in the chat box so that you can access these. Hopefully, you also get the sense that we are trying to make them attractive and not boring government-looking tools, especially given that many are sort of shy away from the importance of data or using data. But this, hopefully, because we are using good, attractive colors, folks will be interested in it and really take a look at these materials as well. Next slide. So, what can you do to support ending the HIV epidemic in your community? Individually, it's important to know your status. If you don't know your status, then get tested. I think we also need to think about how do we scale up and support testing efforts in communities, and thinking about sort of those places where individuals live, work, and play, that we could offer testing since not everybody is going to walk into a clinic. At the beginning, we played the video from Damian, who talked about PrEP and talked about the machismo in society, in his community that he experiences as a Puerto Rican living with, who is an MSM. But at the same time, you know, we have some of these societal and cultural issues that get in the way that cause individuals not to go to the doctor, not to trust the doctors, not to walk into clinics. And I think that's why it's important to have the community at the table to really educate both our public health entities and our community-based entities to really think about how we promote HIV testing as well as care and treatment and how we work to overcome some of those barriers. We also need to encourage those who are living with HIV to get into care and also figure out how to support them staying in care and helping them achieve and maintain viral suppression and aligning their personal priorities with these public health priorities as well. The other thing I will say about ending the HIV epidemic is that we cannot end the epidemic without considering the role that race and systemic racism plays in American society. Another reason why it's important to have the community at the table to be part of the planning and implementation is to be able to have those really frank conversations about how racism, stigma, and discrimination impact the access, how it impacts the delivery, and whether or not individuals stay in both prevention and care, as well as treatment, or even want to go get tested. These are things that we at the federal government can't necessarily solve. Me as a gay Black man living with HIV, I don't understand, I am aware of the issues that someone might have who comes to this country whose Spanish is their first language, and the challenge of getting and staying in services or finding service providers who understand your culture, who understand your language. I'm aware of those issues, but I haven't lived that life. But meeting folks who have that lived experience, who can share that with me, enables me to understand some of those challenges and to work collaboratively to figure out how we do this differently. Before we went on lockdown, here, can we go to the next slide? Before we went on lockdown, due to COVID-19, I had the opportunity to do some traveling both in San Diego and in Riverside, San Bernardino, out in California. And there were some individuals that I met from the Latinx community who had a lasting impact on the way I thought about this work. One was a woman who, up until a month before she met with us in January in San Bernardino, she had just found out about her diagnosis. And she found out about her diagnosis because her husband had passed away. And her husband had been ill. He had been tested for lots of diseases, and they finally gave him an HIV test. They gave him an HIV test. He tested with AIDS, and he passed away within 2 months. And here was a woman who, this was the first time that she had been in a room with other people who were HIV positive. She felt like her life was over, and she was still in grief and mourning from the loss of her husband. And just watching the individuals in that room care for her, share their own stories of living with HIV, and tell her that she would not be alone and that she could live, created a lasting impact on me, because I thought, here we were in 2020, and this is a story that I have heard for 20 years of being in this field, and yet it's still happening to individuals. At that same meeting, I met a young man who English was not his first language. He was in the San Bernardino area. He had heard that there were services for those living with HIV. He knew that he had HIV, and he had to, on his own, figure out how to navigate the system to get the help that he needed. And he was so worried that his English wasn't that good. But as he explained to me what he had gone through, he did that completely in English, because I'm sure you all remember from the start of this presentation, my Spanish is not that good. But I was impressed with his resilience, his tenacity, and his ability to figure out how to get the services that he needed in our fragmented American system of healthcare. And it left me with the impression, and what I remarked about was his English to me was great. His tenacity was impressive. And his resilience is really what stuck with me, as well as the fact that we've got this fragmented system that even if someone knows that there are services out there, they don't know how to reach them. So with that, I hope you have found this presentation helpful. I hope that I've left you with a lot to think about in terms of the challenges we have in ending the HIV epidemic, but I hope that I've also left you with the thought that together we can do this, and that at the federal level, we're very serious about trying to do this. And we cannot do it until we have really the community working with us and helping us understand and design these services in a lot better way. So thank you. My next slide, I think, gives you information on where you can get additional information on ending the HIV epidemic. And I think the last one tells you how to get in contact with me. These slides will be made available both in English and Spanish for you all, and I really hope that you use them in your communities. This year, I've been very excited to learn that there have been a lot of Spanish language town hall meetings that have been happening. I know LA County is planning another one. There was a group yesterday that had them. Our prevention through active community engagement officers were a part of that. And so please join us in this effort, and I look forward to taking questions if we have time.
Yes, we have time. Thank you very much, Harold. There are some questions. Before going to the questions, I want to answer something that's been asked on the chat. You will receive this presentation by email. I'm going to try to get the English version as well, so I can see them together, and the recording of the webinar, the link of the recording. So there's 6 questions here in the question and answer. One is from Jamile Stockett. It says, I'm Jamile, coordinator for Ending the Epidemic and Fast Track City Initiative in Durham, North Carolina. I have a question about how the plans differ from state to state or county to county.
That's a really good question. In the plans, revisions to the plans are due December 31st of this year. The initial plans were sent in. CDC, HRSA, and our office, the Office of the Assistant Secretary, reviewed them and provided feedback to the jurisdictions. They're currently incorporating that feedback. But the plans for each jurisdiction have to be different, because in each of the counties and states that are part of EHE, their epidemic is different. The populations impacted by HIV are different. If you go to the AHEAD dashboard and take a look at just a few of the counties, you can sort of see the difference. And so if you're really engaging the community and thinking about what services look like in your community and how you're going to use this federal funding to fill in the gaps, it's going to be different for each community.
How did you do that? I can't open that.
Right.
Yes, there is another question here from Nikki Chopra. What do you think the 55 plus population specifically has shown an increase in HIV rates?
Too, no?
That's a really good question and an interesting question as well. I think that, we have known for a while, well, one of the reasons is people over 55 still have sex. And the other piece of this is that also people over 55 are also, especially during this time of where we've got all these sort of intersecting national traumas, people are still just trying to make it through every day. So a lot of the ways that we cope, alcohol, drugs, sex, all sort of fuel HIV transmission. And people over 55, as people are living longer, and the baby boomers are definitely in that over 55 group, they're still engaging in risk behaviors. And what we probably haven't done very well is deliver messages to that group. So I think that's fueling it.
Okay. Thank you. There is a comment and question from Murray Penner from Prevention Access Campaign. Always good to hear Harold present about ending the epidemic. Thanks. I noticed on the slide with federal agencies that were a part of the ending epidemic, CMS was not included. With Medicaid and Medicare both providing healthcare to many people living with HIV in the United States, why is CMS not a part of an epidemic? Or what progress is being made to get them to join as a participating agency?
So great question. CMS, for those of you that don't know, oversee the federal Medicaid program. And Medicaid is the largest payer of HIV care and treatment for people living with HIV. And so Medicaid, we are taking steps with the Office of the Assistant Secretary to bring them into the EHE work. And also, we're putting together some very specific asks for Medicaid. So I hope that over this next year, we'll see more and greater involvement in them, because you're right, they are a key partner that needs to be at the table for HHS. I think they weren't included initially. They were not included initially, let me just say that. But we have recognized and had some conversations with the Assistant Secretary's office about ways that we can bring them in. So next year.
Kevin Cedar asks, Harold, you state undetectable means non-transmittable through sex. Is it also non-transmittable through needle sharing?
Is his with PrEP? Is that part of Kevin?
No. He said that you mentioned the undetectable means untransmittable through sex. He's asking if it applies to needle sharing.
I think so, because once, well, and I may ask Murray to chime in on this one. But if someone is virally suppressed and they're sharing needles, the risk of HIV transmission, they won't transmit HIV, but they might transmit other infectious diseases as a result of that. So, and so this is one of the reasons why syringe services programs are also important, not only because they help decrease HIV transmission, but also viral hepatitis, which is something we have to watch out. So, and Murray says the evidence is not as clear for needle sharing as it is for sexual transmission. Mm-hmm. Thanks, Murray.
There's another question from Ashley Underwood. Hi, my name is Ashley Underwood, MPH. I work as a program manager for the PrEP program at Washington University in St. Louis, Missouri. Our program is currently using HIV self-tests, and I wanted to know your thoughts on the reliability of the oral quick test, which is the only FDA-approved test. I know there are a few other tests that are approved by the World Health Organization and the European Union using blood from a finger prick that seems more reliable.
So I think right now, you're right. The OraSure test is the only FDA-approved test in the United States. CDC has released guidelines on the use of that test during this time and has approved it, and also let their recipients know that it's all right to purchase HIV self-test using CDC funds. I think right now, and that will, I think, continue for as long as we're in this public health emergency. So programs have been encouraged to go ahead and use them, especially if that is the only way or one of the major sources for the continuation of HIV testing services during this time. So hopefully that helps.
John Parisot asked, how are the labs pay for Ready-Set PrEP when they use?
So, as I said, the medication itself is free, but to cover the cost of the labs, there have been several things that have been done. One is funding, I want to say about $70 million worth of funding went to community health centers to cover the cost of labs. That's one way. And also CDC most recently in August as part of scaling up HIV testing and PrEP programs, also distributed several $1 million to public health departments to cover the cost of labs. So those are ways that sort of the federal government is supporting the cost of the labs while providing free access to the medication.
Omar Martinez asks, many Black and Brown run CBOs are currently and considering applying for the epidemic initiative funding. These agencies have been historically underfunded. Funding reasons include not having capacity or not being as competitive as others. However, we know the true core reasons are the structural barriers: systemic racism, discrimination, rooted oppressive practices, and reviewers' biases. Can you provide some suggestions and recommendations for grant writers at these Black and Brown agencies to make these proposals competitive and fundable?
So I think that for the applications to be competitive, one, I think really and truly making sure that you adhere to and answer the questions in the federal application guidance. I think very often when some folks are writing grants, they don't pay attention to the questions that are being asked. And the questions that are being asked and how you respond to them is so important because there are points associated with answering the questions and not telling the story that you want to tell. You can tell the story that needs to be told about the community or the lack of services, but ensure that you're doing it in alignment with answering those questions. The other thing I think is being able to demonstrate that connection to the community or to the target population that is identified in the federal grant application, and being able to show that you have a long history. And then the last thing, and this goes to capacity, your capacity to stand up these programs very quickly is also an important thing to demonstrate in a federal grant application. Because very often the funding might be, even if the funding is 3 years worth of funding, in most cases, they don't want you taking a year to start up the new program. So if you can demonstrate in your grant application that we can get this money, we can start quickly, and we can be enrolling or serving the community quickly within a month or a few months, that puts you ahead of the game than someone who says, I'm going to take this grant out money and it's going to take me a year to hire staff or to, remodel a room, if remodeling is available, is an option, versus I'm going to come in very quickly and begin to serve clients. So I think those are two things in general that I think can be very helpful as you're thinking about and writing grants. Being able to stand up quickly, provide services, long history of connection to the community, and making sure that you are following the guidance and answering the questions.
Yeah, we are running out of time. There's a few more questions, but we want to at least answer one before we finish. Cassandra Esperant says, I'm a pharmacist at AHF Pharmacy, and I had to turn away a patient because we do not take ready-set PrEP. How do we get at it?
So I think in turning away the patient, I hope that here's what maybe you figured out how to do at AHF is to serve that patient with a client, with the labs, with the other pieces, and then write them a script that then hopefully they can take up the street to one of the participants and still be in the program. Currently, for the Ready Set PrEP program, the only pharmacies that can distribute the medication are the 26,000 pharmacists that are within the network. But we're hoping that between the pharmacists that are there and that our network of providers, that you all are still providing the lab testing, all the rest of it, the counseling, and working with those pharmacies to coordinate that care.
I keep on forgetting that I put mute. That's all the time that we have for today's webinar. Thank you very much, Harold, for this amazing presentation. And thank you, everybody, for the participation, the questions, and the comments. I hope to see you all next week for our last webinar with U equals U, the message. It's going to be on Thursday, the 22nd at 3 p.m. The link you will receive by email. Thank you again, Harold, and thank you, Marisa.
Thank you all.
Thank you.
Bye.